Good morning, everyone. Yeah, thank you for your patience on the technical difficulties. Yeah, we're thrilled to be here. Thank you to Renee for inviting us. We are members of the Pediatric Palliative Care Service at Boston Children's in Dana-Farber, also known as Pediatric Advanced Care Team, or PACT. As was introduced, my name is Shih-Ning Liaw. I'm one of the physicians with the team.
I'm Chelsea Hennigan. I'm one of the nurse practitioners.
And I'm Lauren. I'm one of the social workers for the team.
Clearly more resourceful than we are. Yes.
Who's a social worker?
And that's
on
why
stage?
she's a social worker. Yes. So yeah, we're just thrilled to be able to come and share the next hour with you. In thinking about how palliative care can help support families and patients in facing heterotaxy together. I love the name of the conference. So just some brief objectives. Hopefully in the next hour we'll be able to define and conceptualize what pediatric palliative care is, identify some of the domains of our practice, and describe how we as a team and palliative care teams as a whole can support patients, families, and teams in serious illness communication and decision making. It's a taste of what we do on a day-to-day, and we hope that this can help fill out the picture of how palliative care can serve you as families. So let me start with an illustration or an observation. One is that really just that medical terminology is weird and confusing. And so just follow this conversation with me. And this may be a conversation some of you may have experienced yourself. In this scenario, a family has learned about a prenatal diagnosis of hypoplastic left heart syndrome. And in meeting with a cardiologist, cardiologist might say, well, we can do a single ventricle palliation. Wah, 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 wah. More details about the heart anatomy, heart physiology, what surgery sounds like, blah, 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 all the risk benefits. Basically, the takeaway is that what that means, a single ventricle palliation, that it's a highly intensive, multi-staged open heart surgeries over many months to years, and that these surgical procedures, the word palliation here means that these surgical procedures do not fully repair the heart. It doesn't recreate or reconstruct the heart to become a four-chambered vessel, but instead it reroutes and reattaches the plumbing, if you will, to help make the cardiovascular physiology work better for longer. We now have, this is the standard of practice. This was new like 20 years ago. This is now a very established standard of care, but it is still a very high-risk surgical plan and with lots of potential for serious complications and even death. And then so in thinking about and talking about these complications and death, and in this context, the cardiologist may also say, maybe we don't do surgery, and we can do palliative care. And in this conversation, essentially palliative care here means let's not do surgery, no intervention, and focus on comfort and end-of-life care, recognizing that the time for your baby is short. Without surgery. So just in this one conversation, the words palliation and palliative care are used to describe vastly different treatment pathways. They come from the same Latin root word, and yet they mean very different things. Out of curiosity, has anyone in this room encountered a confusing conversation like this, or had a conversation like this with their doctors? Wow, many hands. I know it's first thing in the morning, but would any of you care to share what that felt like, or what that experience was like in the moment for you?
They haven't had their coffees
I
yet.
know, and it's okay if you don't. Yes.
I mean, for me personally, it was just that I'm trying to understand this, right? And I feel like a lot of times the doctors just assume you understand, and they're throwing, I'm kind of get to a point where you can understand enough to help guide you to understand. And it's very, very overwhelming.
Yeah. Thank you so much for sharing. And I'm not surprised to hear that, right? This is a confusing term. It's a confusing phrase. Different doctors use it in different contexts. Even the medical literature search engines are confused by this. So when I was preparing for this talk, I went to PubMed to look for articles, medical articles about palliative care for patients with heterotaxy. And it gave me dozens and dozens of articles about cardiac palliation surgeries, that first bullet. But only one of them discussed palliative care. And in this article, it made a recommendation that families of patients with heterotaxy syndrome would greatly benefit from the early involvement of pediatric palliative care services. Now wait, what? If palliation means to do surgery and palliative care means not to do surgery, why would patients with heterotaxy benefit from early palliative care? So this is just confusing because we're dealing with three different definitions of practically the same word. And so we want to spend some time unpacking that and helping to think through and define and perhaps redefine what palliative care is and how it can serve patients with heterotaxy. So in 2011, the Center to Advanced Palliative Care, or CAPC, did a public opinion research, basically a Gallup poll, using the term to investigate how the general public thinks about palliative care. And when just thrown out there, what do you think about palliative care? What is your favorability rating? The general public gave about a 35% favorable rating. It's like, look, I don't want to deal with end-of-life care, but I suppose it's important in some cases. So 35% gave a favorable rating. When the term palliative care was associated with a definition and a description of what it does, the favorability quotient, if you will, the favorability skyrocketed up to 92%. Patients and families who heard this definition and understood what it meant felt like it was overwhelmingly a positive service, and many felt that it was important that they themselves or family members would receive this type of service if they were in this situation. So this is the definition that is still on the CAPC website. That palliative care is specialized medical care for people with serious illnesses. Its goals are to provide patients and their families with relief from the symptoms, pain, and stress of a serious illness. It's to improve quality of life for both the patient and the family, and to serve as an extra layer of support by a team of doctors, nurses, and other specialists who work collaboratively with the patient's medical team, and to care for any patient with a serious illness at any age and at any stage of illness to support their goals of treatment. When we think about that definition and think about how to conceptualize it into patient care, this is how we consider it. We consider that pediatric palliative care can work to prevent, identify, and treat different types of suffering in children with serious illnesses, and we work to support their families and the medical teams that care for them. It's appropriate at any stage of the illness and can be provided together with disease-directed therapy. It's not an either-or, you do surgery or you don't, but that for all patients in any course of their illness, there's a proactive approach. There's a recognition of the wide impact of the child's illness on the family and their caregivers. And we provide individualized support at multiple levels for all people involved, with the goal of aligning care to the goals of the patient and family. Palliative care is always delivered in an interdisciplinary way. That's why we have physician, nurse practitioner, and social worker here. And we recognize that there is that suffering comes in different forms, and distress and stress comes in different layers. It's not just medical decision, but that you're facing, but all these other things that come with it. And that palliative care service can provide a longitudinal or continuity role at different levels or different stages of the illness as things move forward. We recognize that as a patient perhaps gets sicker or things get more complicated or complex, that if it looks like things are trending towards the end of life, we also have the expertise to help support patients and families and medical teams in navigating end-of-life care, and we provide support for bereavement beyond that. At all times in a patient's life, we recognize that there is both a hope for cure, life extension, and miracle, even when things look bleak, and there's always going to be a hope for comfort and meaning, even when things are going well. And so we recognize that families hold that hope, hold worries, hold all these things throughout a patient's life, and we help to support all of that. So with this definition and conceptualization of palliative care in mind, the way palliative care is delivered in our healthcare system today looks different depending on the setting and context. There's one distinction called primary palliative care and subspecialty palliative care. And primary palliative care is defined as care that is provided by non-palliative care specialists. And these include the core competencies of empathy, communication, pain management, shared decision-making, and ethical decision-making that any clinician should have when caring for patients with serious illness. Think of this as palliative care provided by your cardiology team or your complex care team or your ICU team during the course of everyday treatment. As the medical condition becomes more complex, sometimes subspecialty palliative care is consulted to help support the family and the team. Subspecialty palliative care, as I said, is always provided by an interprofessional team, and that seeks to provide a whole person, whole family approach to care. Subspecialty palliative care teams are often based at hospitals to provide inpatient and outpatient consultations, while beyond the hospital setting, there are community-based palliative care services or teams that seek to bring some of this care and this approach into the home. These services often look different in that these community-based services are generally less medically intensive, but may provide support in other ways, like child life, or massage therapy, music therapy, things that traditional insurances may not cover. As a patient trends towards end of life, hospice may become a service that is introduced, and it refers to a specific care delivery model that specializes in end-of-life care and symptom management, particularly in the home setting. And finally, bereavement programs serve families whose child or loved one has died. So we'll spend the rest of our time describing different domains of subspecialty practice and kind of peeling back the curtain a little bit, getting you a little bit more in the granular details of what we do and how we do it. We'll describe in more detail how we support medical teams and families in clarifying prognostic understanding about a patient's illness, and how does this understanding then help families determine their goals of care for their child, and how can pediatric palliative care support families and teams to make decisions that align with these goals. How do we help families anticipate and plan for what lies ahead? How do we manage distressing symptoms that arise during the course of illness? As many of you have experienced firsthand, facilitating streamlined and consistent communication in a hospital setting can be quite challenging, and we're there to try to help. Palliative care teams are critically important to educate and support the medical teams to continue providing serious illness care. And palliative care teams often provide bereavement support as well. So when we think about the term prognostic understanding, what does that mean? I think one of the most common reasons palliative care is consulted is for us to help elucidate goals of care for our family. And you may have even heard clinicians ask you as parents, what are your goals for your child? To help them determine what to do next in their treatment. In our experience, we find that medical teams often jump to this step without first clarifying whether there's a shared prognostic understanding of the situation. So when we meet with families, a critical part of our initial assessment is to explore whether families and medical teams are on the same page. Is there information or are there knowledge gaps that need to be addressed? And we may ask questions such as, when we meet with a family, what have you heard about what to expect with your illness? Or what do you understand about your child's illness? We assess communication preferences. How do you like to receive information? What information would be most helpful for you right now? And how do you want to be involved in conversations about what to expect? Do you prefer big family meetings where there's all sorts of subspecialists in the room, or would you prefer it to be streamlined through one or two providers? This is an essential first step in identifying where we are in a shared understanding, both with the medical team and the family, before we then enter into discussions about goals of care. But why is this step so hard? Why is prognosis or delivering a prognosis or communicating about prognosis so hard? I think the first point that there's just so much uncertainty in the trajectory and the course of any complex patient, particularly children with heterotaxy, where every patient, every kid is individual and unique and different. There's just so much uncertainty that it is hard for the medical team, the ICU team, their cardiology team to give any information with clarity or certainty about it. But I do think, and we've all been in positions where we've seen patients do better than we expect. So, the teams are human. They also want to maintain hope and establish that therapeutic balance, alliance with families, and don't want to take away that hope, even in the face of potential bad news. And because of these tensions, data does show that the medical teams tend to avoid conversations or defer these types of conversations. Only 3% of recorded conversations include prognostic discussions, and when they occur, many caveats and softening statements are included. Yet, a clear understanding of prognosis, what teams are worried about, what teams think might happen, greatly affects treatment decision-making, end-of-life care decision-making, and bereavement outcomes. So we understand that shared prognostic understanding is a process. It takes time. It's more than just one conversation. But it requires iterative reassessment over time. As more clinical data is available, that factors into how a medical team might conceptualize or think about a patient. And that also affects how that information and prognosis is shared. As a palliative care service, we are there to support and often coach teams to help deliver clearer and more concise prognostic information that can help families with establishing and thinking through goals of care and the future. So once there is a shared prognostic understanding, we feel that is what families need to be able to then truly explore and think about how that factors into their hopes and their worries and their priorities. We acknowledge and normalize the coexistence of many goals, and sometimes name that some of these goals may not be possible or may be conflicting in the context of complex medical decisions. And in thinking through that, we can anticipate and identify inflection points in which goals might require reassessment. We understand that goals of care aren't just medical goals. Families' goals are grounded in hopes, worries, values, and experience. Unlike medical providers, parents do not rely solely on risks and benefits to make decisions, but the goals of care represent a consolidation of parental experience, your emotions, your perspectives, and your priorities. There is emerging literature in different patient populations to help us better understand the patient and parental experience of living with serious illness. The most studied group is the pediatric oncology population, and while there are some similarities, we recognize that there are many important differences compared with other populations. There is not yet any cohort study focusing on heterotaxy syndrome, but there is a growing literature base that studies and describes the experiences and needs of the congenital heart disease population and medically complex population. I think palliative care, more than any other subspecialty, focuses on the illness experience. We strive to take a holistic approach in understanding what matters most to each patient and family, and to ensure care that is provided in a way that best honors these goals and values.